Thank you very much for having me today. I have no conflicts to disclose. So for today's session, we're going to review the results of our study looking at the oncologic outcomes of women undergoing radical hysterectomy in Ontario, and we're going to consolidate this data with existing literature. So as I'm sure many of you know, the use of minimally invasive radical hysterectomy for early-stage cervical cancer has been called into question following the publication of 2 landmark studies in the New England Journal of Medicine. Both the laparoscopic approach to cervical cancer randomized trial and an observational study using the National Cancer Database have both shown that minimally invasive radical hysterectomy is associated with anywhere from a 2 to 6-fold increase in the rate of all-cause mortality compared to open radical hysterectomy in this patient population. These results were unexpected and have certainly been met with some skepticism in the medical community. And I've included a few excerpts from some editorials here just to demonstrate some of the common criticisms, which have been an insufficient amount of data on disease recurrence. The NCDB study was not able to look at that outcome. A need to evaluate the underlying mechanism for these findings, and in particular, the impact of surgeon volume on that relationship, and a need for confirmatory studies in other jurisdictions with sufficient sample sizes and follow-up. So to address these concerns and to also examine data in a Canadian context, we aimed to compare the survival and recurrence outcomes of early-stage cervical cancer patients undergoing minimally invasive versus open radical hysterectomy across the province of Ontario while accounting for surgeon volume. So to do this, we performed a population-based retrospective cohort study using multiple linked administrative databases held at ICES. ICES is a nonprofit research institute authorized to collect and use health data on all Ontario residents for the purposes of health system evaluation. So we included all adult women diagnosed with cervical cancer from 2006 to 2016 who underwent primary radical hysterectomy by a gynecologic oncologist within 9 months of diagnosis. Patients were identified from the Ontario Cancer Registry, which contains records for all incident cancers in the province. And we used validated Canadian classification of health intervention codes to assign patients to either the MIS or open group. So our primary outcome was all-cause death, and our secondary outcome was recurrence, treating second cancer and death as competing events. We used a marginal Cox proportional hazards model and a marginal cause-specific hazards model to evaluate the association of surgical approach with all-cause death and recurrence, respectively. We used robust variance estimators to account for the clustering of procedures within surgeons, and both of our models adjusted for age, year of surgery, material deprivation, which is a measure of socioeconomic status, comorbidities, pathologic stage, surgeon technique-specific volume, and surgeon cervical cancer volume. So technique-specific volume was the number of hysterectomies performed by the patient's surgeon with the selected approach in the 1 year prior to the index surgery. And cervical cancer volume was the number of procedures performed specifically for cervical cancer in the 2 years prior to the index surgery. And for our primary analysis, we dichotomized these variables at the 50th percentile into high and low volume, but also performed several sensitivity analyses, which I'll mention later. Because we hypothesized that the effect of surgical approach may vary based on stage of disease, we included an interaction term between these variables. These interaction terms were significant, so they were included in our final models. So after exclusions, we were left with 958 cervical cancer patients who had had primary rad hyst by a gynecologic oncologist. 485, or about 51%, had an open surgery, and 473, or about 49%, had a minimally invasive surgery. Of the minimally invasive cases, 90% were laparoscopic and 10% were robotic. Over time, you can see that the use of a minimally invasive approach for radical hysterectomy increased significantly, with the proportion starting at around 5% in 2006 all the way to 65% in 2017. These are the baseline characteristics of our cohort. I'll just highlight that we use standardized differences to compare the balance of variables across treatment groups, with anything over 0.1 indicating a meaningful difference. So patients having minimally invasive surgery were slightly younger, had surgery, of course, more recently, and also had fewer comorbidities. We had access to pathologic stage, not phycoclinical stage, and so you can see here that patients having minimally invasive surgery were more likely to have stage 1A disease and less likely to have stage 1B or 2+ disease. And here 2+ disease represents patients with high-risk pathologic features, things like parametrial involvement and lymph node involvement. Minimally invasive patients were also more likely to have a high-volume surgeon, both for the specific technique, whether it was MIS or open, and for cervical cancer. So in the overall cohort, the unadjusted cumulative incidence of death and recurrence was not statistically different across surgical approaches. At 5 years, the cumulative incidence of death was 7% in the open group and 9% in the minimally invasive group. And the cumulative incidence of recurrence was 11% in the open group and 13% in the minimally invasive group. But when we stratify by stage, you can see that the cumulative incidence of both death and recurrence are significantly increased for patients undergoing minimally invasive surgery. And this was specifically in the 1B subcohort of patients. So at 5 years, the cumulative incidence of death was 5% in the open group and 13% in the minimally invasive group. And the cumulative incidence of recurrence was 8% in the open group compared to 16% in the minimally invasive group. So in our multivariable models, also adjusting for patient factors and surgeon volume, we see that minimally invasive surgery is associated with a twofold increase in both death and recurrence. And this was, again, specifically in the 1B subgroup and not in patients with stage 1A or 2+ disease. So you can see the point estimate and the entire confidence interval lies above 1 for the 1B patients, but not for our other patients. Sensitivity analyses where we adjusted for surgeon volume in tertiles as a continuous variable, dichotomized on yearly volume to account for temporal trends, and also including adjuvant therapy as a covariate, all showed the same result, so about a twofold increase in both outcomes. We also looked at cervical cancer-specific death in a subset of 770 patients for whom we actually had cause of death data available. We didn't have enough events for multivariable modeling, but we were able to look at, again, the unadjusted cumulative incidences of these outcomes. And you can see that cervical cancer death for the complete cohort is not different across surgical approaches, but again, in patients with stage 1B disease, you see that minimally invasive surgery is associated with an increased rate of cervical cancer-specific death. So to conclude, minimally invasive surgery is associated with a twofold higher rate of death and recurrence compared to open radical hysterectomy in patients with pathologic stage 1B cervical cancer. And so this study does confirm the findings of the LAC trial in a Canadian jurisdiction. You may notice that the hazard ratios, both in our study and in the NCDB study, do not reproduce the large values that we're seeing in the LAC trial. And I think there's two key reasons for that. The first is that both our study and the NCDB study are observational, so there is going to be residual confounding, and in particular, neither of our studies are able to completely account for intermediate risk factors. So if surgeons are more likely to or tend to select patients with larger tumors or more aggressive tumors for open surgery, then that is going to result in an underestimation of the risk associated with minimally invasive surgery. The other key point on the flip side to recognize is that the LAC trial was stopped early due to evidence of harm and had very few events. So there's quite a bit of literature supporting the fact that trials that are stopped early after interim analyses often overestimate or exaggerate the treatment effect. So with additional follow-up and accumulation of more events for the LAC trial, we may actually start to see those hazard ratios come down closer to what we see in the observational studies. So it's I think to emphasize that is it's not that minimally invasive surgery is safe, but that it may not be as bad as what it appeared to be at the moment the LAC trial was finished. So in terms of what our study adds to the literature, so we still found evidence of harm even after controlling for surgeon volume in numerous ways as it changed over the course of the study period. So this may suggest that the underlying mechanism is independent of surgeon volume. We did not find statistically significant associations in patients with stage 1A or 2+ disease, but we were underpowered in these subgroups. So while we can speculate from these findings that there may be a subgroup of patients with early stage microscopic disease for whom minimally invasive surgery is still safe, I think additional studies with more patients, really granular pathologic data, and ideally a randomized design would be needed to make that claim. And that's it. Thank you. I'm happy to take any questions.
Thanks for staying on time.
Yes, hi. Were you able to stratify your data according to tumor size under 2 and over 2 centimeters for the 1B group of patients?
That's a great question. Unfortunately, not. We don't have that tumor size data in the administrative databases that were available. The only distinction we could make was from 1A and 1B, but that's ultimately something we want to look at, and we should be able to
Because if you have access to the pathology reports or pathology data, should you not be able to?
So we can get the pathology data from Cancer Care Ontario, but it will require some extra abstraction, and that's something we plan to do to add onto this study.
And then I suspect you don't have data on the technique per se in terms of the cupotomy, manipulator, and all those sorts of things.
No. I think the important thing to take away from this study is it really reflects real-world practice, what is happening in Ontario with the surgeons who do this procedure, regardless of the specifics of how one surgeon or another may do it. It really reflects real-world practice and what's happening in the province.
And just to follow on that, you don't have numbers that actually had no residual disease in the final specimen?
So again, that's something that that's the next step, yeah.
Stay tuned.
Yes, exactly.
All right.
Okay, thank you very much for giving us the opportunity to present. I'm presenting on behalf of a research team on adherence to cervical screening guidelines for women with low-grade abnormalities. So I have no financial disclosures to report, and I also am not going to be discussing any off-label use. These are the learning objectives. So as many of you in the room know, screening pap smears, the abnormals that come back are for the most part low-grade abnormalities, and in the literature this represents about 6% of the abnormal pap smears that we come across. And for the purpose of this talk, I'm going to refer to low-grade abnormalities as ASCUS and LSIL pathologies combined, or cytology, I should say. Low-grade abnormalities remain very challenging for clinicians. They lead to high referral rates to colposcopy, which can lead to patient stress, anxiety, and can also lead to overtreatment in a lot of our younger patients. And we also know that the majority of patients that have these low-grade abnormalities are your patients in the 21 to 29-year-old range. So the objective of this study was to identify underlying risk of in situ and invasive cervical cancer for the low-grade abnormalities in pap smear screened women in Ontario. This was a population-based retrospective cohort study with women who underwent an index low-grade pap smear in 2010. We linked the results with administrative databases, and these women were followed on average for 5 years. We collected screening pap smears that followed the index pap smear, referral to colposcopy, and occurrence of cervical cancer and carcinoma in situ that was identified during the study period. So patients that were included had to be registered with OHIP. They had to have a cytological low-grade abnormality, and they were excluded if they had a prior hysterectomy or prior abnormal cytology within 2 years. In addition, women who had a subsequent pap smear within 14 days or a diagnosis of a cervical cancer within 14 days or referral to colpo within 14 days, they were excluded from the study because we were trying to weed out kind of diagnostic pap smears. Okay. So looking at our results, this is the table 1 of the study, you can see that for all women that had a pap smear that could be eligible for inclusion in our study was about over 500,000 women, but those with a low-grade abnormality was about 22,000 patients, and that represented about 4% in this cohort, so consistent with the literature. Again, the majority of patients in our study cohort were the 21 to 29-year-old range. And looking at the cancer occurrence in these groups, and we stratified in this table based on ASCUS versus LSIL, those that had an in situ disease with an index ASCUS pap smear had about a 3.2% chance of having an in situ disease at some point, and an invasive cancer of about 0.1%, so very low. Those with an indexed LSIL had a risk of an in situ cancer of 5.9% and a chance of an invasive cancer of 0.2%. We wanted to characterize these patients who had the ASCUS and LSIL pap smears a little bit better over the 5-year study period. And here we stratified based on age less than 30 and greater than 30. And we looked at multiple things, but I'm going to focus on, in the sake of time, regression to normal prior to referral. So these are patients who had at least 2 pap smears done. And you can see that regression rates were quite high. So if they had an index ascus and they were less than 30, they regressed to normal prior to their referral for colpo 53% of the time. And if they were greater than 30, it was 64% of the time. Similarly, LSIL was in the 45% range. So this is a little bit of a complicated table, but we wanted to look at rates of colposcopy and treatment by common profile. So we actually were able to come up with more than 30 profiles. That's a really busy table to show you today. So I've highlighted some of the kind of important combinations that you might see. And first, looking at if you had an ascus followed by a normal pap smear, your chance of even participating in any colposcopy was very low, and of getting any treatment was very low, 1.1%. If you had an ascus followed by a high-grade lesion, then your chance of getting treatment was high, 60%. If you had kind of persistent disease, persistent low-grade disease, again, you had a high chance of getting referred to colpo and a high chance of getting treatment, about 17 to 26%. So similarly with the index LSIL, we see the same pattern. So low chance of getting treatment if you were low followed by a normal, a high chance of getting treatment if you were low followed by a high-grade pap smear, and then if you kind of had this persistent low-grade disease, again, it was about a 1 in 4 chance that you would get any kind of treatment. Now looking at the standardized 5-year incidence rates of having an in situ cancer based on these referral profiles. Again, a busy slide, so hold on with me. Here we go. Okay, so if you had a low-grade pap smear of any kind followed by a normal, the chance of you having an in situ disease is very low. It's less than 0.5%. If you had a low-grade followed by another low-grade, your chance of having in situ disease goes up a little bit, anywhere from 5 to 10%. If you had a low-grade followed by a high-grade, the chance of you having in situ disease was higher, obviously, anywhere from 31 to 48%. So we also did this table for invasive cancers, but most of the standardized incidence rates were 0%. The highest that we came across was 2.6% in an indexed LSIL pap smear, followed by high grade. So again, quite low rates of invasive cancer when your index pap smear is a low grade. So I apologize, there's an error on this slide. It says number needed to treat to prevent one, but it's actually to detect. So the number of colposcopies that we would need to detect one carcinoma in situ or invasive cancer, if you started with an index ascus, you need about 10 colposcopies to detect an in situ or invasive cancer. And if you started with an index LSIL, you need about 8.5 colposcopies to detect an in situ or invasive cancer. So some of the strengths of this study is that it is population-based, and we have access in Ontario to a large comprehensive database. But of course, limitations is that it's administrative, it's retrospective in nature, and we actually don't have the HPV status or vaccination status of these patients. So to summarize, we feel that low-grade abnormalities have very high clearance rates, and for the most part, it's very safe to follow these patients with pap smear rather than immediate referral to colposcopy. Immediate referral to colposcopy really does cause a lot of anxiety to our patients, and that's well documented in the literature. And so you can decrease that kind of stress to your patients, but also it's a big burden on our healthcare resources to be referring early on to colposcopy. As we saw from our data from the different profiles, it's very safe that if you have low-grade lesions that these people can be kind of followed, because the chance of you getting an CIN3 in situ or invasive cancer is very low. Moving forward, HPV is really going to help us triage these patients and our referral to colposcopy. And as we move to either a dual system or a primary HPV model, getting that HPV strain will help us to stratify these patients and their risk. And more than just high-risk HPV, but subtyping the HPV strain, so the 16, 18, and we're kind of looking at, and the kind of people that are very interested in this line of work are looking at what are the different strains that are going to help us stratify patients to colposcopy and who can we watch. So with that, I'd like to acknowledge my research collaborators, and I'm happy to take any questions.
Thank you for the presentation.
Okay,
sorry, you had a question?
You go.
Did you, so two
Sure.
questions, I think, or points. The HSIL or the in situ, you were talking about CIN3 for all of these cases, or were they HSIL as in CIN2, CIN3?
They were CIN3.
CIN3?
Yeah,
Because
yeah.
we know the CIN2 will go away
Yeah, yes.
in a large percentage of cases.
Yes.
Did you see a real difference if you sort of compared L-Sil Ascus or L-Sil Ascus and compare the two? Was there any real difference with any of those?
Not a huge difference, no.
Yeah.
No,
Because-
really, I think that second pap smear is very telling, like the L-Sil, like H-Sil, that
Yeah.
obviously, and then the other patients, and I think the older women who have kind of persistent disease, they're the ones that maybe we have to kind of worry about. But I really think that moving forward, the HPV is going to be
Yeah.
what's going to help us.
I did a
obviously.
similar thing
I saw your paper,
a long
yes.
time ago, but we never saw a difference between the two. I never published this one, but we never saw a difference between L-Sil Ascus, Ascus L-Sil,
Okay.
and they all had a 70% high-risk HPV rate.
Okay.
So
Yeah.
the two abnormals seem to make difference.
I wonder
you.
how you think the HPV will perform in that young age group, which is so problematic, that you're 21 to 29.
Yeah. Well, I think that there is a move to not start even until 25 because we know that young women will clear the disease, and we know that there are some pretty severe consequences that can happen from early treatment. So maybe more frequent monitoring if you are going to do HPV testing, like more frequent colposcopy and biopsies, but watching rather than treating.
So is the reflex in Ontario to refer to colposcopy after one L-Sil pap?
It's not, but it does happen a lot because a lot of family doctors are getting abnormals, and but no, generally. For the ascus, they're supposed to repeat after 6 months, and for L-Sils, they're, they can also repeat pap smear or refer, yeah.
Marcus?
Tiffany, I'm not sure if you have this, but do you have data on rates of reporting based on different labs? You know,
That's a
I think
really
we
good
all
question.
we all experience
Yeah.
that
Yeah.
there's lab X that their
Right.
ascus rate is way higher than others, and I think part
I
of
don't
this
have
data
that, yeah.
is, I mean, it'd be
Yeah.
interesting. I don't know if they could break it down at Ontario level,
Right.
but I think you'd see some very interesting data around the reporting of these.
Sure, yeah, no, I don't have that, but it would be interesting to go back maybe and ask if that's possible to get, I'm not sure.
Thank you. So I'd like to thank the committee for this opportunity. And my talk is titled, Does MMR Deficiency Have Prognostic Significance in Low-Risk Endometrial Cancers? I have no disclosures. And the objectives of the session are to review the outcomes in MMR deficient versus MMR proficient low-risk endometrial cancers, and to review the prognostic and predictive implication of MMR deficiency in endometrial cancer. So as we all know, MMR or mismatch repair deficiency is seen in 20 to 40% of all endometrial cancers and arises from either a germline or a somatic mutation in the genes MLH1, MSH2, MSH6, and PMS2. And it's usually detected as loss of mismatch repair protein expression by immunohistochemistry. And in Vancouver Coastal Health Authority region, we've been testing all of our endometrial cancers since 2009 for mismatch repair deficiency as a screen for Lynch syndrome. Now, what is still undecided or very divided in the literature is the association between MMR deficiency and outcomes in endometrial cancer, and whether MMR deficiency has any prognostic or therapeutic implications. So McKean's GOG study was one of the first to try to answer this question. They looked at over 1,000 women with endometrial cancers and defined their MMR status and found that MMR deficiency was associated with a number of poor prognostic variables, such as higher grades and a propensity for lymphovascular space invasion. But when they looked at cancer-specific survival outcomes, there was no difference in the patients with MMR deficient tumors versus MMR proficient or MMR intact tumors. Which suggests that MMR deficiency may counteract the effects of these negative prognostic indicators. They also did an exploratory analysis to look at the relationship between MMR deficiency and adjuvant therapy and found that those women with MMR deficient tumors that had received adjuvant therapy, those women had a trend for improved progression-free survival. Now, based on that exploratory analysis, our group recently published a paper looking at whether MMR deficiency affects one's response to adjuvant treatment. This was a large retrospective cohort study, and we looked at only those women who had received adjuvant treatment, so they tended to be higher risk disease, and compare the outcomes between the MMR proficient and MMR deficient women. And you can see that the blue graph represents the MMR deficient ladies, and the red represents the MMR proficient groups. And you can see that MMR deficiency is associated with better progression-free survival, overall survival, and lower recurrence rates after adjusting for covariate factors. Now, after our study was published, there are multiple other studies in the literature that support a similar finding, that in women who have received adjuvant therapy, MMR deficiency may be associated with better survival outcomes overall. But the issue is that all of these patients in these studies have already received their adjuvant treatment, and they also come from a very heterogeneous group of populations. So they tend to they look at a variety of different grades, different stages, different histotypes. So it really confounds the true prognostic value of MMR deficiency. So in order to really look at that prognostic value, we looked at our data in only low-risk endometrial cancers, so stage 1A, grade 1 or 2 endometrial cancers, and compare the outcomes between MMR deficient versus proficient cases. So the objective was to assess if MMR deficiency had any impact on the outcomes in this low-risk cancer. So this was a retrospective population-based cohort study based out of Vancouver Coastal Health Authority between 2011 and 2016 with a minimum of 2-year follow-up. We looked at their demographic variables as well as their progression-free survival, overall survival, and recurrence rates. And in order to compare their survival curves, we used Cox proportional hazard regression and created a model adjusting for the traditional covariates such as age, grades, LVSI status, and adjuvant therapy received. So you can see that in total there were 475 women with stage 1A, grade 1 or 2 endometrial cancers in that time frame. And you can see that 344 were MMR proficient and 131 were MMR deficient. And looking at their demographics, MMR deficiency was associated with higher age and a lower BMI. There was a larger proportion of grade 2 disease in the MMR deficient group as well as more LVSI. There were a few women that did receive adjuvant treatment, around 30 out of 475, and the majority were radiation therapy. And you can see in the recurrence rate, MMR deficiency was associated with a higher recurrence rate after adjusting for the covariates that I had mentioned. But when looking at this number, we need to keep in mind that the raw numbers of the recurrence rates that we're dealing with are very low, because as we know, this is low-risk disease that tends to doesn't recur as often as many of the higher histotypes, and overall do quite well. Looking at survival curves, you can also see here that MMR deficiency is associated with worse progression-free survival, but there was no difference in the overall survival. So what does this data tell us? Well, in low-risk endometrial cancers, MMR deficiency may be associated with a higher rate of recurrence and a trend towards worse survival outcomes. And you can see that this is in stark contrast to our previous study, as well as multiple other studies in the literature that actually shows that MMR deficiency may be associated with better outcomes. Now, again, keeping in mind that all of these studies that have been published so far are looking at higher risk disease that have already received adjuvant treatment, and again confounds the true prognostic value of MMR deficiency. One of the possible theories that has been suggested in a recent publication of why MMR deficiency may be linked to worse outcomes is the theory of dysregulation in the estrogen and progesterone receptor, and we know that dysregulation of these receptors is linked with worse clinical outcomes. Now, what is accumulating in evidence is that MMR deficiency is actually predictive for one's response to adjuvant treatment. There was a recent cohort study that has been published that looks at grade 1B and stage 1B or stage 2, grade 3 endometrial cancers, and they found that radiation therapy in those women with MMR deficient cancers led to a better survival outcome, which they did not see in the MMR proficient group. And there was a couple more studies published recently looking at the response to radiation therapy, and a theory that the MMR deficiency may be predictive for radiosensitivity. And the biological basis for why this may be is that in MMR intact tumors with a DNA damage from the radiation therapy with a double-strand DNA breakage, MLH1 and MSH2 have a role in recognizing the radiation-induced DNA damage and initiate the repair mechanism. Also, in a similar setting, when there's a loss of MLH1, it leads to a downregulation of a nuclear factor kappa beta, which is again associated with recognizing that radiation-induced injury. So with the previous studies that have been published looking at these higher risk disease that have been exposed to adjuvant therapy, we are now learning that it may be predictive, MMR deficiency may be predictive for radiosensitivity. And with our study looking at low-risk disease, for which the majority of women did not receive adjuvant therapy, MMR deficiency may be in fact prognostic for worse outcomes. Now, of course, with the recent Health Canada recommendation for using pembrolizumab for MMR-deficient recurrent or metastatic endometrial cancer, the future direction is to exploit increased lymphocyte infiltration in MMR-deficient tumors with immunotherapy. Some of the strengths of the study was that this was a large population-based study with an unselected number of cases, and we have tried to address the prognostic value of MMR in a low-risk endometrial cancers, the majority of which did not receive adjuvant therapy. Limitations include the short follow-up interval. Again, we had a very few number of events for recurrences and therefore may be underpowered to find a true difference. And because of institutional practices, there were a few cases that had incomplete staging, but that proportion was comparable between the two groups of MMR deficient and proficient group. Thank you.
Do you think we need to rethink the role of adjuvant therapy in these low-stage, low-risk patients?
That's a great question, but I think right now we don't have enough follow-up data to conclusively make that suggestion. I think we need a few more studies before we can confidently say that maybe.
Marcus.
Rachel, maybe I missed it. When you put your graph on, because your MMR deficient groups were more likely to be grade 2, more likely to have LVI.
Yeah.
Was that still significant when you factor this on a multivariate modeling?
So, the final survival graphs and the recurrence rates were factored in. The covariates were factored in.
So there was no overall survival difference between the two groups.
Correct.
Yeah.
But difference in the progression-free survival and the recurrence rates.
So I have no disclosures. These are the learning objectives for today. So at the end of the session, should be familiar with our evidence-based SSI reduction bundle that we used in Calgary. Appraise the role of implementing a SSI reduction bundle for gynecology patients, and then evaluating the utility in your own centers if you should be implementing SSI reduction bundles. So there's an ERAS email that started this process. We've got the ERAS guru in Calgary. We started ERAS in September 2016, and auditing is it's an integral part of an ERAS program. And in 2017, there was an ERAS audit, and there was a higher than expected surgical site infection rate. For staging surgeries, it was 14%. For debulking surgery, it was 9%. We didn't know why the staging procedures was higher. And in a few slides, you'll see that it was actually worse than expected. So why do we care about surgical site infections? They can have significant emotional and economic burden for patients. They can delay adjuvant treatment. We know that there's a 3 to 5-fold increase in the length of in a hospital stay, greater than 3-fold rate of readmission, and then a greater than 5-fold increase in reoperation. And the healthcare cost for patients with an SSI is estimated to be about $1.6 billion annually. In 2015, there was a study done by Tranidol that did show that the occurrence of a superficial and an organ space SSI was actually associated with worse overall survival in patients that had surgery for an epithelial ovarian cancer. Studies have shown that we can prevent up to 60% of SSIs. There has been a flurry of publications out recently that discuss SSI reduction bundles. There was one presented last year. There was a study out of Ottawa that showed that there was a reduction in SSI from 14.6 to 5.7%. The Disinfect trial was done out of MD Anderson, also showed a 40% decrease in surgical site infection. It went from 12.5 to 7.4%. This was presented last year out of the University of Toronto, and they showed a 55% reduction in surgical site infections from 12.1 to 5.4%. This CDC article is what we used to develop our SSI reduction bundle. We tried to be evidence-based. Some of our stuff was evidence-based, some of the stuff was more common sense. The objective of our study was to evaluate the effectiveness of the implementation of an evidence-based SSI prevention bundle in gynecology patients. So a lot of this came from that CDC paper. So what we used, so we had preoperative interventions, intraoperative interventions, and postoperative interventions. This all started in the new patient visit. So it started with smoking cessation. We offered patients smoking cessation handouts, ideally 4 to 6 weeks preoperatively. We gave them instructions on using a chlorhexidine wash that they would use the night before. We would avoid hair removal. If we did require hair removal, we would do so with clippers and not razors. Surgical hand scrub, intraoperative skin prep, so using an alcohol-based antiseptic with chlorhexidine, and then parental antimicrobial prophylaxis, and then appropriate redosing. These were our intraoperative interventions, and there had to be a lot of buy-in from several different groups. So there had to be buy-in from the clinic nurses for the preoperative interventions. There had to be buy-in from the OR nurses for these intraoperative interventions. So one of the things we looked at was oxygenation. So having the anesthesiologist administer increased FiO2 during the surgery and immediately after the surgery. Maintaining perioperative normothermia greater than 36 degrees Celsius. Not all the anesthetists monitor temperature. We would change our gloves prior to fascial closure. We had a new instrument tray for closure, so that had Coker clamps and everything on, so that we would use clean instruments. Wound irrigation with aqueous iodine solution, and we would close the subcutaneous tissue if the depth is greater than 2 centimeters. We also changed gowns before closure of fascia if we did bowel surgery as well. These were our postoperative interventions, so the nursing would remove the dressing and cleanse the wound with normal saline on post-op day 1. Patients would shower prior to discharge, and patients were actually given instructions on calling the clinic if they had any concerns about the wound, because we wanted to see the patients. We wanted to assess the wound ourselves. It's not that we didn't trust family doctors, but we just wanted an accurate representation of our surgical site infection rate. This slide is hard to see. This was just our first checklist. And then it was an iterative process. It went through a couple of modifications. This is our most recent checklist. It just simplifies things. It's just a quick check, yes or no. This was a little bit easier to read than that first checklist. So it was a pre and post intervention design. So we had a retrospective group. So we used October 2016 to December 2017 as a retrospective cohort. That was after the implementation of ERAS. And then we started data collection prospectively on January 15th, 2018, and then we used that as our prospective cohort. We included all patients undergoing a laparotomy with the Gynecologic Oncology service. We did exclude our laparoscopies converted to open, and our hernia repairs. We used CDC criteria for the diagnosis of an SSI, so superficial incisional, deep incisional, and organ space. So the results, so we had very similar baseline characteristics with the exception of diabetes, pre-op albumin, midline incision, and Phanencedil. More patients were diabetic with our prospective cohort. It was 17%. Midline incisions, we were doing 96% of our laparotomies with the midline incision prior to January 15th, 2018. And then Phanencedils, we brought that up to 28%. So any SSI, so pre-SSI bundle, if you remember back to that initial slide, it was 14% and 9%. It was much worse than we had expected. We were 26.6%. So a quarter of our patients had a surgical site infection. Post-SSI bundle, we did bring that down to 20%, which is still very high. Most of the surgical site infections came from UTI, so it went from 11.5 pre to 4%. This superficial incisional SSI diagnosed by surgeon, this is just the surgical site infections that we had diagnosed. So we had diagnosed 50% after the SSI bundle because we are asking patients to come back, call the clinic, ask them to come back for a visit. The deep incisional SSIs was not significant, but there was a trend towards a reduction from 5 to 2%. And this was if we were compliant with the SSI checklist. So compliance was only 40%. It was a little bit better if we were compliant with the SSI checklist, 18.1% versus 26.6%. And then again, the deep incisional went from 5.1 to 2.4. And our biggest difference was in our staging procedures. So staging procedures went from 26% to 18%. There was a non-significant increase in our debulking procedures. I don't know why that is. We did do some logistic regression modeling to predict any SSI. So if we were compliant with the SSI checklist, you had odds ratio of 1.68. We compared we compared the different BMIs when you compare it to less than 30, and the only BMI that was associated with an increase in SSI was over 40 with the odds ratio of 2.28. Length of surgery and bowel resection were also significant. We looked at the different tumor sites, so ovarian cancer, benign, endometrial cancer, cervical cancer. None of those were statistically significant. So we did show a 68% decreased odds of surgical site infection when we were compliant with the bundle. The highest risk factors for SSI in our cohort was a BMI greater than 40, prolonged surgery, and bowel resection. So it's an iterative process. The checklist continues to evolve to improve compliance. One of the things we can consider is adding the checklist to our synoptic reporting for improved compliance, and then establishing a shared care model with internal medicine and preoperative clinic for our risk factor modification. like with the Ottawa study looking at perioperative glycemic control. These are my references.
Any questions?
I just wanted to ask about the your wound closure. How do you close the skin?
We close the skin with staples.
Yeah, 'cause I know when we introduced this bundle, the big controversy was you go into subcuticular, and for all incisions,
Even the midlines?
which was a bit of a change for us. But in our experience, that we intuitively or anecdotally feel that contributed significantly to our drop in Ottawa for wound infections.
Yeah.
So I don't know what the other experience is in the type of wound closure, skin closure. Do you know any literature around skin closure, or did it have been sorted out in the bundle?
We didn't sort that out in our bundle, and the issue with having these bundles is that we don't.
Can't tell.
Yeah, we can't tell what made the biggest difference. There was that non-significant decrease in deep incisional wound surgical site infections, and is that because we were cleansing the wound with iodine? I don't know.
Are you capturing all of your surgical site infections? In other words, do all of your patients in Calgary return to Calgary your hospital, or are you missing? Do you know how many you might be missing?
We could be missing some, some that are from out of town. We do get some patients from BC, from Cranbrook, and if they end up benign, then they end up not coming back to see us for their post-op visit. They can see their gynecologist in Cranbrook, so there may be some patients that we're missing, so we may be even higher than 26%, which is a little bit embarrassing.
Why do you think the rate's so high?
I don't know why the rate is so high. I don't know if it's in Calgary. We have 3 separate ORs within the Foothills Medical Center, and Gynecology will typically operate on the 7th floor OR, and we don't have laminar flow in that OR, which became very evident when the high-level fires were going on, and my eyes were watering in the OR, and you can smell the smoke inside the OR room.
Two questions.
I believe you had.
Sorry.
I believe you had a higher rate of UTI infections. Did you guys develop, or do you have some kind of protocol about how to place the Foley catheter, how to keep it, not raising it above the level of the patient so urine doesn't flow back into the bladder?
We don't have a protocol for placing the catheter. The FlexiTrack came in. I don't know if that made the difference in our UTI. That just fixes the catheter to the medial aspect of the thigh. I don't know why there was such a significant decrease in our UTI.
Greg?
Yeah, I was just going to say as a comment, I mean, the problem with audit is sometimes, you think you know what you're doing, you think you're doing well, and then sometimes you understand that you're not doing so well. Mm-hmm. So obviously here, I mean, we certainly pride ourselves in Calgary on doing big surgery, but sadly, unfortunately, big surgery often equates with, some, big complications, especially from the standpoints of SSI. I mean, obviously, Brent and Anna Cameron are doing a great job of trying to drive that down, but we clearly have a long way to go. So, I applaud sites that are able to get down to 5%. I think as Brent brings up, there's some current talk in the literature around knowing what's happening in your own basement. Yeah. So there's only so much we can do as surgeons intraoperatively, postoperatively, preoperatively, but we're working with our infection control team to look at what's the level of sterilization. I mean, how are the instruments coming up? So is it possible that we are completely missing the boat and it has to do with airflow and other things? But
it could be.
Right.
Anyway, yeah, clearly I would encourage all of you, if you don't know what your SSI rate is, you should start to look at it, because that could be contributing to major morbidity.
I'm curious, are you guys using VEC dressings as part of your ERAS protocol, or do you have guidelines in terms of who you may use a VEC dressing on post-op?
We routinely do not use VAC dressings. We use VAC dressings for patients that have a surgical site infection, but routinely we don't
Not
use.
routinely, that's
Yeah,
right.
we don't use those PICO, those superficial
Farina.
back dressings. We don't.
One more question.
Thank you. Sorry, just to follow up on the previous question. So do you know in terms of how do you compare with other specialties at your surgical specialties at your institution? Like, is this something that in general surgery as well, they
Surgeon,
notice the
correct.
trend compared to across Canada, if they have higher rates or not?
We haven't looked at that. I would love to, because surgical oncology operates on the first floor. I would like to know what their surgical site infection rate is, or colorectal surgery, what the surgical site infection rate would in the McKeg OR, which is a newer OR. But that's something we certainly would need to look into.
Thank you.